In this series of ECG basics, today I will talk about pericarditis and the ECG changes in pericarditis. First is the disclaimer. Caring Talks YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided by this channel is for educational purpose only. It should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention, treatment of medical illnesses. There is no endorsement for any brand or a company. Pericarditis. It is an inflammation of the pericardium which is secondary to infection, localized injury, or systemic disorders, producing the characteristic chest pain, dyspnea, and serial ECG changes. Chest pain is often retrosternal in nature, pleuritic, and positional. It is relieved by sitting forward and get worsen while lying flat. There may be associated pericardial friction rub or ECG evidence of a pericardial effusion. Widespread ST segment changes occur due to involvement of the underlying epicardium, that is myopericarditis. Transthoracic echocardiography is useful in the early assessment of the patients with suspected pericarditis to look for complications such as large pericardial effusion and cardiac tamponade. The characteristics ECG changes which are seen in pericarditis are widespread concave ST elevation and PR depression throughout most of the limb leads, that is lead 1, 2, 3, AVL, AVF, and the precordial leads V2 to V6. There is reciprocal ST depression and PR elevation in lead AVR and plus minus V1 lead. Sinus tachycardia is also common in acute pericarditis due to pain and or pericardial effusion. The ST and PR segment changes are relative to baseline found by the TP segment. The degree of ST elevation is typically modest, that is 0.5 to 1 mm. In this ECG, we can see the PR depression and ST elevation in lead V5. Here we can see a reciprocal PR elevation and ST depression in AVR. There are 4 stages of pericarditis and based on ECG changes. In stage 1, we get widespread ST elevation and PR depression with the reciprocal changes in AVR. It occurs during the first 2 weeks of the pericarditis. The second stage, stage 2, here there is normalization of the ST changes and there is generalized T wave flattening, and it is usually seen in first to 3 weeks. Stage 3 is characterized by flattened T waves. The flattened T waves, they become inverted and it takes 3 to several weeks. And stage 4 is when the ECG returns to normal and it is seen several weeks onward. Less than 50% of the patients, they progress through all the 4 classical stages, and evolution of the changes may not follow this typical pattern. The causes of the pericarditis can be primary versus secondary, acute versus chronic, or infectious versus immune mediated. This is the types of the pericarditis, that is, it can be primary or secondary, acute versus chronic, and infectious versus immune mediated. And the causes are, for infectious causes, the mostly it is seen post viral or in cases of viral diseases like Coxsackie virus. Occasionally the bacterial causes, fungal causes, and tuberculosis are implicated in the Cause of pericarditis. The immunological causes are SLE and rheumatic fever, uremia, post-myocardial infarction, trauma, paraneoplastic syndrome. Drugs like isoniazid, cyclosporin, and post-radiotherapy are the important causes of the pericarditis. The differential diagnoses of pericarditis are pleurisy, pneumonia, acute MI, bony pain, costochondritis, and angina. In this ECG, we can see widespread concave ST elevation and PR depression throughout the precordial leads, that is V2 to V6, and limb leads like lead 1, 2, AVL, and AVF. There is also a reciprocal ST depression and PR elevation in AVR. This ECG shows sinus tachycardia, widespread concave ST elevation, and PR depression in limb leads and precordial leads, and reciprocal ST depression and PR elevation in V1 and AVR. In lead 2, we can also see the spodic sign, which I already discussed in my previous videos. It is another example of pericarditis. Here we can see widespread ST elevation and PR depression, and reciprocal ST depression and PR elevation in V1 and AVR. This ECG shows acute myopericarditis. There is marked sinus tachycardia, widespread subtle concave ST elevation with PR depression, most obvious in the precordial leads, that is V2 to V6, and inferior leads. There is a reciprocal ST depression and PR elevation in AVR. How do we differentiate pericarditis versus benign early repolarization? Usually the pericarditis can be difficult to differentiate from benign early repolarization, as both conditions are associated with concave ST elevation. But important useful trick is to distinguish between these is to look at the ST segment and T wave ratio, and sometimes the fish hook pattern. The ST segment to T wave ratio is the vertical height of the ST segment elevation, that is from the end of the PR segment to the J point. It is measured and it is compared to the amplitude of the T wave in V6. The ST segment T wave ratio, if it is more than 0.25, it suggests pericarditis, and if it is less than 0.25, it suggests benign early repolarization. So here we can see uh, uh, in left-sided ECG, the ST segment height is 1 mm, T wave height is 6 mm, the ST T wave ratio is 0.16, that is less than 0.25. It is consistent with benign early repolarization. And on this right-sided ECG, the ST segment height is 2 mm, T wave height is 4 mm, ST to T wave ratio is 0.5. This ratio is more than 0.25. It is suggestive of pericarditis. Again, we can see another clue which suggests benign early repolarization is the presence of notched or irregular J point, the so-called fish hook pattern, and it is best seen in lead V4. And when it is present, it is suggestive of benign early repolarization. So, in benign early repolarizations, there is ST elevation limited to precordial leads, absence of PR depression, prominent T waves, ST segment T wave ratio less than 0.25, characteristic fish hook appearance in V4, and ECG changes usually stable over time, that is, they are non-progressive. In pericarditis, there is generalized ST elevation, presence of PR depression, normal T wave amplitude, ST segment T wave ratio is more than 0.25, absence of fish hook appearance in V4, and we get dynamic ECG changes that evolve slowly over time. Similarly, we can differentiate pericarditis from ST elevation MI. The classical teaching of generalized concave of ST elevation and PR elevation in AVR is not reliable for distinguishing pericarditis from ST elevation myocardial infarction. Pericarditis can cause localized ST elevation, but there should be no reciprocal ST depression except in AVR and V1. The ST elevation MI, like pericarditis, can also cause concave up ST elevation. Only ST elevation MI causes convex up horizontal ST elevation. ST elevation greater in lead 3 than lead 2 strongly suggests ST elevation MI. The PR segment depression is only reliably seen in viral pericarditis, not by the other causes. It is only an early transient phenomena lasting only for hours. MI can also cause PR segment depression due to atrial infarction or PR segment elevation in AVR. So we can't rely on the history either. ST elevation MI can also cause positional or pleuritic pain, a pericardial friction rub. So we should always look for feature of ST elevation MI first. Search for ST depression in lead other than AVR and V1. Look for ST elevation in lead 3 more than 2 and search for horizontal or convex upward ST elevation. If the above are absent, additional findings suggestive of pericarditis include PR depression in multiple leads. There is suggestion of this is suggestive of pericarditis. However, 12% of the patients with ST elevation MI have associated PR depression. We can get spottic sign in pericarditis. Always get serial ECG on any patient with chest pain, and things may become more obvious with time. Albert Einstein has said, only a life lived for other is a life worthwhile. Thank you. Keep learning.